So if it shows carcinoma in situ at that biopsy or operative resection fulguration, how are you going to manage that patient? So 3-month cysto, biopsy-proven carcinoma in situ after induction BCG.
For me, my standard of care option would be actually a full induction course, like a second induction course of BCG. And as I sort of alluded to, we have a clinical trial option as well as BCG plus alternating doses of intravesical gemcitabine because, although some patients, the SWOG maintenance randomized data would suggest that about 50% of patients would convert from a non-responder with CIS to a complete response at their 6-month assessment. 50%, that's essentially a coin toss more or less. So, hoping that either that full 6 weeks of BCG or that clinical trial, as I alluded to, and I think there's other clinical trials that will probably be that are assessing BCG plus immune checkpoint blockade, et cetera, may see if, there may be better efficacy with a combination. Although personally, we'll talk about this in a bit. I always have a little bit of concerns about the toxicity for an immune checkpoint inhibitor.
Yeah. So what if their cytology is positive and you don't biopsy prove any persistent cancer? Does it take a little while for the cytology to kind of seroconvert? Are you worried? Are you doing urethral biopsies and random bladder biopsies and blue light cystos, Tim? Ureteroscopy, selective cytologies? Are you going for BroCare, or how do you kind of synthesize that?
I think post-BCG, there is a role, or at least the guidelines do state the possibility of utilizing some other markers as well, such as Eurovision, FISH, and immunocyte, or even CX bladder, which everybody seems to be hot on. But we are not utilizing any of these. I don't think it changes management given those current tests. So for myself, if someone has a positive cytology, you go and you biopsy, you don't find anything that's still residual, I just continue with the maintenance BCG courses at that point. I'm not doing anything extra.
Eugene?
Yeah, I would agree. And I think, as you suggested, do the same. Sort of alluded to, I typically will take prostatic urethral biopsies as well as selective cytologies for patients, especially if their bladder looks like there's obvious carcinoma in situ. I typically will not, because those will almost always be positive and probably just contamination. I'll still probably do a sampling of the prostatic urethra in males because I do worry for someone with diffuse CIS that, there's some stuff hiding out there. So I'll do full TUR loop biopsies from 5 to 7 at least. But as just like Tim said, if the biopsies all come back negative, or the prostatic urethra is negative, I will often counsel patients that CIS, by definition, doesn't really adhere very well. And it's not uncommon to find denuded mucosa. So to me, if you have a positive cytology and you have denuded mucosa, it's just indicative that the CIS cells are being shed into the urine. And I think in that situation, maintenance BCG would be totally reasonable.